Okay, I think we're going to go ahead and get started. Good afternoon. My name is Selena Solis. I am your host for this section of the Summit program, and I'm a commissioner on the JSMH and also the presiding judge of the 243rd District Court in the far west Texas town of El Paso. Before we begin our next session, I wanted to bring your attention to a great technical assistance opportunity that the JSMH is offering in January. Earlier this year, the JSMH ran the first of its kind Mental Health Courts Collaborative, and I was actually a part of that collaborative. Over the first 3 months of 2024, judges who wanted to start a mental health court who had a brand new mental health court, such as myself, convened together on Zoom to learn about grants, funding, data collection, ethics, and best practices for treatment courts. The participant judges were also paired up with mentor judges. I had the honor to be paired up with Judge Brent Carr and other judges who had presided over mental health courts for a while. And I cannot tell you it was extremely valuable, and it helped me during the course of this past year. In 2025, JSMH is changing the collaborative a little bit. They are going to expand it to include judges who want to start treatment courts related to alcohol and substance use issues, like DWI courts and drug courts. It's going to be called the Treatment Courts Collaborative, and it will start in January 2025. It is completely free. Most things are not free, but this is free. And participant judges will also get a free registration to the Texas Association of Specialty Courts Conference in the spring, which I believe this year is in Corpus Christi. Applications for the Treatment Courts Collaborative are on the JSMH website. They are also at the JSMH resource booth, or you can find Molly Davis, who will be carrying applications with her. So please find Molly if you have any questions or would like to apply to the Treatment Courts Collaborative. Our next session is called Evidence-Based Treatment for Substance Use Disorder. Ensuring that evidence-based treatment services are available for the children and families of individuals who suffer from a substance use disorder is critical to their success. During this session, you will learn about the importance of having access to and using a continuum of evidence-based substance use treatment resources, from inpatient residential treatment to outpatient services. Referral processes, case planning, use of family-based therapies, mental health services, and applying trauma-focused care for youth and families will be discussed. Erin Rodriguez is the president and owner of Selah Clinical Services, P.C., which is a private practice and consulting firm for trauma, mental health, and addiction. Without further ado, help me welcome Ms. Rodriguez.
Thank you, everyone. So, well, this is really echoey. Okay. So one of the things I wanted to start with is we have handouts that have different evidence-based curriculum. There's some in the front and some in the back. Make sure you grab those just as some ideas, I guess, of things that you can use. Okay, the next thing we're going to talk about, or we're going to start talking about, is the fact that this session isn't just about the curriculum. It's about the practices and the services that go along with it and how we get there. Disclaimer, everything that I say today is of my opinion, and it's not necessarily components of, it's not nobody else did this, okay? I should have read this slide. I'm so used to this slide, but I just didn't do it today. Now, if everyone remembers NADCP, we are now All Rise, and that's who I'm here with today. We are formerly the National Association of Drug Court Professionals. One of the things that we have done is rebrand, and the reason for that is because we're much bigger now, right? And we have lots of different areas. And I like the way that it is rebranded because it really fits the different things that we're doing. We're not just drug court, right? It's impaired driving court, it's justice for vets, it's actually what I'm here for is the juvenile section. But we do a lot of the different things that really take a look at the evidence-based practices per those different divisions and how we can utilize those around the nation to help our clientele. Here's some of the learning objectives for today. The early engagement and why this is so important, a continuum of care, and the evidence-based treatment. Now, these three words tend to be words that are kind of thrown around like buzzwords, but what I have found is that us as treatment providers don't actually explain it in a way that the courts can put it into practice or even understand fully what that means. I'm hoping we can get to that today. We're going to start with early identification and engagement in treatment services. So, the first thing that comes to mind when I talk about that is motivation, right? And I don't know if you guys have ever heard this, but your brain is not your friend. Have you heard that? Your brain is not your friend, right? And here's why. Did you know action comes before motivation, right? So if I get up and I want to go to the gym, I don't want to go to the gym. I have to start that action before I become motivated, right? Here's the other part. Motivation is very closely tied to feelings. So the closer that we get to the incident that has happened, the more motivation we are going to have for that individual to engage in the things that we would like them to engage in. Here's the other part of this. When we enter somebody into the court, I wish that that was the day that they stopped using, right? It would be really so much easier on us if that's what happened. If we enter them into the court and we do not have treatment services ready or available, what happens? A lot of times, they're getting themselves into a little more chaos than we would like, right? But here's the other piece. We start behavior modification, whether we're doing it wrong or right, from day one. So we enter someone into the court and we're like, well, they're not in treatment yet. So we're going to overlook all the behaviors that are going on because we are not helping them in these areas. What are we doing from a behavior mod point of view? So things that we need to remember is that when we use screening tools the way that they are provided to us and the way that they are intended to use, it really helps us with that early identification and entrance into the treatment courts. I like screenings because they're quicker and they can be done by individuals that don't necessarily have some of the letters behind their name that is needed for a full assessment. That's super helpful in areas where you have a lot of people coming to you, right? Assessments are a good couple of hours. And if we had to send absolutely everyone to that because we didn't know whether they were appropriate or not, then that whole early identification piece might be pushed out longer or early entrance into things simply because we didn't have the manpower. So full disclosure, as a treatment provider who's been in the field since 2007, I didn't always know the difference between screening and assessment, like how to explain it. And so I started asking, and here's why I didn't know. As somebody that does assessments, I often use screenings as assessment tools. And so when people are like, well, is it screening or assessment, right? So here's the way that I started to explain it. A screening can be done by somebody in a short period of time to identify a problem or a need for further assessment, right? Screenings are also really, really effective. You are trying to identify different evidence-based practices. I'm going to get into some of that a little bit later, so I don't want to repeat myself because I tend to do that if I get into it earlier. Here's the other piece of that. We have on here positive drug test results. I would do a full assessment sometimes, and they would say, I don't use, I don't use, I don't use. Okay, let's go get that drug screen today. Now, all of a sudden, I have a whole nother set of things, right? But that is not simply the one thing that would constitute them being able to come into a program that's this rigorous, right? Timely access to appropriate treatment. Now, we started talking about this, and there's two places that I've lived in my life. One is in Montana and one is Texas, okay? But the one thing that I have noticed is that there are a lot of systems around the nation where that collaboration piece or that communication piece, we're not hitting it quite as well as we should. Maybe it's because it's a rural area. Maybe it's because we have 25 to 50 different providers. But the one thing that is in the research is that if you have these collaboration and communication protocols, then we can hit this part a little bit quicker. Now, I talked about the brain and how it's not your friend, right? But here's another reason why your brain is not your friend. How many of you try to make changes in your life, right? All of us. And for some reason, it's really hard. Even, for instance, like stopping the use of sugar, I bet you there's probably only a few people in here who've never tried to do that, right? How many times do we relapse on sugar? And we're not even talking about the stuff that's inundated, the stuff that really gets that dopamine rush in these brains, right? Like a heroin, like a fentanyl. Those do not even compare, right? Now, I don't want to use sugar again. And those of you that have went off and on and off and on of different things or dieted, I'm sure you don't want to either. So what makes us start again, right? Now, we could go around the room and there'd be all different ideas, but really it is your brain chemistry and the things that your brain is really wanting. Now, if you have juveniles, this is going to be a little bit more difficult. How many individuals in here have juveniles, right? Now, individuals in between the ages, and I have 5 children, don't judge me, but 3 of which are teenagers all at the same time, right? So I learned something very, very clear. I really needed to understand the differences between the juveniles in my practice, the juveniles in my home, and the adults that I was helping serve, because there is a difference. And that's one of the reasons why evidence-based practices are so important with that population as well, because we don't have to reinvent that wheel. Ideally, participants are referred to treatment within 24 to 72 hours. Now, when we say that, we wish we all had that, I know, right? Are there strategies that we can utilize to help us with that? When we sentence somebody into one of the courts, what's in place to start day one with the motivation, right? Are there strategies to improve our relationships with the treatment individuals that maybe are on our team or that might be servicing some of our clientele? Sorry, this is to help us with this part. Those of you that have been in this arena for a long time maybe have even lost individuals in those first couple of days, right? Because I know that we have, most of us already have. It's another reason why this is so important. Treatment matches assessed needs. Now, oftentimes I'll visit courts where treatment will come and they'll say, Erin is appropriate. Great, let's start. But if that is all you get from treatment, how are you going to know how to effectively serve that individual? Here's the other part. We tend to think we know based on family, right? If the individual is going to be okay or not in the court. In fact, we've even heard people say, well, I know Erin's family. Her brothers have been in and out of prison. Her dad this, her mom that. We are not taking her, right? But when we have universal screening in place, and we don't have to make that guess, boy, does it cut down on some of the team discussion, right? It just is what it is. On screening, on paper, maybe we shouldn't judge them based on their family dynamics. The other part of this that I've often seen, and we don't do it on purpose either, is we assess them and then we just put them in whatever level of care we have available, right? Now, it really doesn't seem to be an issue until it is. When you use a standardized assessment, you can say this, and this, right? And right now, Erin is assessed at needing a level 2.1, which is IOP. Judge, that is a minimum of 9 hours a week, and right now, all we have available is 5, right? That's perfectly appropriate to say. If that's all we have available, that's all we have available. But by saying that, we are being accountable for them being in a lower level of care than what is assessed to be needed, which means we as a team are going to have to make sure that we are putting things in place. So if this individual starts to have some issues, that we remember that, and it's not another failure on their part. Justice-involved individuals and substance use providers jointly determine appropriate services and level of care. What does that mean? It doesn't mean that I'm not going to anything but outpatient 1 day a week, and I get to choose that. That's not exactly what it means. It means that if, say, I am assessed out to need an inpatient level of care, and I have littles at home, and I have no one to watch them, right? And I just simply can't do it, that I get a say in that. And sometimes what that looks like is me saying, okay, you're assessed at needing a residential level of care. And I hear you. You can't find any place for your children to go, but you're entering into the treatment court. If we start you at an outpatient level of care, I want you to know that if you fail, don't use that word, sorry. If you are not able to make the changes necessary in that level of care, you know that residential is still on the table. So we're going to work with you, right? However, it's not off the table. That's what it looks like. It doesn't look like me getting to tell the court, well, I'm going to go to Mariana over here 1 day a week, right? Treatment is not provided to reward, punish, or serve other non-clinical goals. Now, one of the things that we see in treatment is if it's tied to the court, sometimes they just don't necessarily tell us what's going on. Because if we are holding them longer because we need to work on something, they may view it as a punishment. And they really want those positive kudos, they want to be doing good, and they want to move forward. So if we allow treatment to do the amount of time treatment needs, especially with these high-risk, high-need individuals, outside of that, then we are facilitating individuals to be more honest about the things that they need to be honest with. Ongoing assessment. Does anybody in here watch Chris Rock? He has a skit, right? And it says, when you date someone, you don't really meet them the first date. You meet their representative, right? And the second date, you still got their representative, but sometimes maybe by the third, you might get the real them. I feel like that's assessments, okay? It really is. And that's why on that first assessment, as a treatment provider, I may not have all the answers for that. And I may not know all the different things that are going on. You all might see that representative too, right? Okay, we're going to talk about a continuum of care. Here's the other reason why this is important. when you're doing a full assessment, and it's one of the ones that tells you all the different things, we need time. We need time to get to this, and we need time to implement it so the individual can live life on life's terms, right? I'm telling you what, with the individuals that are under the age of 24, everything seems to be working against, well, I'd say us, in helping them move toward a life of recovery. Friends are super important, right? Oftentimes, their family actually needs treatment a little more than they do, right? Or therapy. And we have to teach them not only, hey, let's get sober, but now you're going to be in your home, back into this area, life on life's terms, right? It's really, really easy, or it's easier for individuals to remain abstinent in an institution, whether it is jail, whether it's inpatient treatment, whether it's residential. But once they get out into the community and life starts to happen, it becomes a little bit more difficult. So, when level of care is determined by that initial assessment and is ongoing, we see better outcomes. And that level of care is told exactly how it is. Not, they're appropriate, let's sentence them in, everyone's going to go to this level, right? Now, treatment dosage and duration are sufficient. These individuals that are high risk, high need are going to need a longer duration. And oftentimes, one of the main things that we do in these specialized courts is offer that to them, right? Has anybody in here looked at the research behind the relapse rate of coming just out of a 30-day inpatient program? It is through the roof, yeah. Why is that? Because they're coming from an institution, right? And they're going back out into the community, and what happens? Your brain is not your friend, right? And things get really tough, and all of a sudden you're at home, right? Or you're here, and all the different traumas and feelings and stressors come up. Do you know what cuts down that relapse rate? Aftercare. Stepping down into a different level of care. Now, when we don't have all the different levels available, putting things in place for recovery management areas. What is recovery management? It's lots of different things that I'm going to talk about here in a minute, but I want to make sure that I say this. I took for granted that they would understand what pro-social activities were, right? And I learned that simply putting that on a treatment plan, simply putting pro-social activities in phases did not mean that I was meeting them where they were at, and did not mean they understood what to do. Here's the other part of that. Clients have actually said, I don't know how to talk to people of the opposite sex without alcohol or drugs. I've actually never done it, right? And although we don't want them dating, they're eventually going to date, right? You know, I ran a relapse prevention group approximately 10 years ago, or I don't know, it was a really long time ago. And I had an assignment toward the end of the court that was do 2 leisure activities a week. And you would have thought that I was ripping people's arms off at the socket because they were so angry with me, right? And I finally had to sit down and be like, why are you not doing this? What? I mean, I'm asking you to go out and have fun. And they didn't know where to go, they didn't know what to do, and they definitely didn't have the resources available to get it done. They felt weird, they felt awkward, they didn't have friends in that area, right? Not to mention that the court didn't want them hanging out with other people from the court, okay? Okay, I'm gonna get into parts of an assessment so that we can really take a look at what treatment does and what they look at when we are developing not only a treatment plan, but taking a look at different areas that need to be in that continuum of care, that step down, the duration that's needed, and also what evidence-based practices to use. Texas uses ASAM, correct? You guys use ASAM? Do we have treatment providers in here? Okay. So there are 2 different ASAM books right now because 4th just came out. And there is enough similarities that if your providers are using 3 or 4, I'll go into both. There's not that many differences. But the first one is intoxication, withdrawal, and addiction medicine. Now, this area is pretty self-explanatory, right? This is, are they going to use? And what is the risk of withdrawal? I oftentimes challenge people to put on here, if you are being released from a controlled environment, which jail is not treatment, you need to put on there that they are at a high risk of acute intoxication and withdrawal potential. And we as providers need to make sure that these clients are not dying. What does that mean? It means we are educating them on the fact that their tolerance is going to be lower. We are educating them on the fact that if they use, when they get out, they could die. We are educating the family, right? Maybe even offering Narcan. We are also telling them that with fentanyl, you could crash over and over and over again. So one Narcan isn't usually going to save your life, right? Biomedical conditions, this is the one area that consistently will bring individuals to a higher level of care. This is really health problems. Now, in the veterans treatment courts, we have a bigger number of individuals that have issues in this area. But the rest of them, a lot of times, this area is a little bit lower, which is why they kind of say IOP is like that sweet spot, right? And it tends to be the sweet spot because individuals with high risk and high need assessments, right, have some of the same sort of issues. So psychiatric and cognitive conditions. Now, when I talked to their representative that first session, right, as somebody that can diagnose, I cannot really diagnose that session because I don't know whether it is residual from substances or whether it is, you know, what came first, the chicken or the egg? And it actually doesn't matter what came first if we're going to address it. The cognitive conditions, this is an area that we often miss because we can't tell from most people whether they have the ability to understand us or not, right? Now, there is a screening, there's a couple of them, but one of them that we utilized was called the Shipley. And all it did was give sort of this cognition number that I could tell the court. So when I would go in and I would present a new client, it would be like, hey, this is Erin. She has an A score of 7, which I'll get to later. But judge, her cognition is at an 84 with normal range being 90 to 100. Why would I say that? Here's why. We assume that people understand the way that we do. And when we give directions, we assume that if they don't follow those, it's manipulation. Another reason why I tell them what it is so we can make accommodations ahead of time, not in front of everybody in the court. So I'll say something like, so as a result, she has been given a notebook that she is to bring to court. And when she's speaking with you, she is going to write down the different things that you tell her to do. If she forgets that, you'll see me writing and I'm going to hand it to her. She also has a buddy that's going to help her with her homework, right? Now, when we individualize care, it would be really nice to know that, right? If you have an individual that cannot seem to think outside the box. The next area, the substance use related risks. This is an area that really overlaps with a lot of what probation does. The R&R, the risk, needs, and responsivity, right? Because I'm going to put in this area their peers. I'm going to put in this area the different things that might be risky for them. Not just their use. I'm going to put, there's use in their family, right? Or they have a history of driving intoxicated, right? In section 4 of this, I put a lot of different things that I can just add evidence-based curriculums to. The recovery environment interactions. Now, if I ever win the lottery, hands down, what I'm going to do is get housing across the nation. Because not one time have I ever went someplace and they said, oh, we're good. That's the one area we have down, right? But here's the other part of that. I've also went a lot of places where, because of lack of housing, everybody goes to a sober living. Now, they can't live in sober living forever. And so what's the exit plan, and what does that look like for long-term recovery? The other things in the recovery environment interactions would be family dynamics, right? I've only met one juvenile over the years that I thought, wow, his family really has it together, right? And here's what I mean by that. We often talk about how addiction is a family disorder, and meaning it affects the whole family. But then when we get the juvenile there, oftentimes I'm heard, well, they're just delinquent. How does it change in that area, right? It doesn't. Also, oftentimes, things are under the radar about what's going on with the juvenile. So we would like them just to go home because they have this great family. But the juvenile is not going to tell us all the different things that go on behind closed doors, right? So building that trust with them and knowing things aren't always what they seem. And oftentimes, many different things lead to them being in front of us. Another recovery environment interaction that I would put down is, say they are a single father or a single mother. And so they're really needing to work. How does that affect what we're doing, right? What about school? I've had individuals that got in trouble for not going to school from day one, all day, every day, when I could not get them stabilized on a mental health medication to help them actually get through the day, right? And so when we're thinking about that part, the fact that we can't always engage in all the things that we're supposed to engage in day one, we start to think about it a little bit differently. The person-centered considerations is part of what we use to make the treatment plan. It doesn't count into their level of care. That's the other 5 areas. Now, when your treatment provider comes to you and says, hey, their assessment's done, they're appropriate, oftentimes we don't know all the different things that are in these levels, right? But you could know some of it. Earlier I mentioned, hey, this is Erin, she has an ACE score of 7. Now, ACE score means it's the Adverse Childhood Experiences Screening. It's 10 questions, it's free, and I have already given education to the entire team about what a high ACE score means. So when I go in there and I say, Erin has an ACE score of 7, they're gonna know that there are certain things that are going to happen or going to be a little bit more difficult without me sharing all the different chaos or different things in the history. This is a different look at levels of care. I had somebody recently tell me that they didn't recognize or realize that we had so many different levels of care. I don't have a lot of time, but I'm gonna end with this part on this slide. I don't want everybody to assume that level 3.1, where they're living in the house, is enough treatment to hit their treatment goals when they're a high-risk, high-need individual. In fact, some of these homes that are level 3.1, these individuals are going for less than 5 hours a week. That's not always what is needed with the long-term sort of change for these individuals. The last part, they've added long-term remission monitoring, which is huge for treatment court. Why? Because of life on life's terms. This is the third edition, that was the fourth. And what I want to show you here is outpatient is anything less than 9 hours a week. How many individuals come to you that have no risk of using, that have no biomedical conditions and no emotional, behavioral, or cognitive conditions and complications? Not a lot, right? And I put the criminal thinking patterns under 3. This is important because when we're giving them less than that, right, we may not see progress the way we would like. Now, like I said before, a little bit about the family and the juvenile within the system. Starting to facilitate new relationships is really, really important. If you ever get a juvenile in there that's like, I'm not stopping use. Marijuana is the first time I ever felt okay, right? My brain stopped. And the parent's like, you're just gonna stop. Now, I don't know what came first, right? The chicken or the egg. But one thing for sure is that if they are identifying that this is the first time their brain stopped, we may want to look at some previous mental health concerns, right? And we may want to help the parent get to the point with this individual or with this teenager where they listen to their words and not just watch their behavior. It's called PCIT, Parent-Child Interaction Therapy. Love this. Love this, why? Because a lot of the individuals that are in some of our courts were never parented, okay? And so now they're learning to parent their children, and we can get them in there playing with them with a little headphone in that says, respond this way, and here's why, right? Family-centered treatment is really, really important. And one of the big things with this is that they are defining what their family is. Not us. Not us by our cultural backgrounds, right? And then we can provide services that are going to help that whole family system. Here's the other thing about this. For individuals that have domestic violence in the home, how important is it to learn new ways to identify, to maybe stop that, to change, or the kids in the home, how to handle this if it's not going to change? Okay, evidence-based treatment. One of the things that's really, really important is the treatment provider qualifications. Are they licensed? Do they have, or a certification? Are they accredited? What are the caseload sizes? If we have a caseload of 20 people in the group, we all know that we have individuals that are going to talk, which is fine until 8 of them don't say a word for a month because it's the show from over here, right? And how does it differ with child welfare population? How does the treatment provider handle high-risk, high-need individuals, and do they understand the adolescent brain? Now, when I say how do they handle treatment or high-risk, high-need individuals, there is some research out that's very, very scary. And I can't remember the exact number, and I think the exact number changes based on the research, but over 50% of all treatment providers in the United States are not equipped to handle high-risk, high-need individuals, right? So what that means is that we can utilize and do treatment adjustments. We can saturate them with hours and hours and hours of treatment. And if the treatment provider is not utilizing these services and aren't equipped to handle it, we are not going to see the outcomes that we're hoping for. That is a very, very scary thing if you think about it. So we're going to talk a little bit about evidence-based manualized treatment. On the different sheets that you were handed, there's lots of different manualized treatments on there. A lot of them are CBT. Now, cognitive behavior therapy, or CBT, is an umbrella term for different modules and different things underneath that. It works really, really well with individuals within the justice system. It helps with thinking, it helps with feelings, and it helps them really put this into life on life's terms. We have to make sure that our treatment providers are equipped to handle co-occurring disorders. I'm going to talk about this a little bit more in a minute because I thought I had an hour and I have 45 minutes, so I got to kind of roll through this a little bit quicker. I apologize. 87 to 93% of all individuals that walk into the court with a substance use disorder have trauma. That's 9 out of 10. And we missed the boat on that because the diagnosis of PTSD is really kind of all over the place, but it's only in between like 3% and 40%. But the research indicates 9 out of 10, which means most individuals coming in already have a co-occurring. It's going to be the exception not to have one. Substance use disorder often is what happens to cope with trauma, mental health, abuse, different things going on. And we cannot miss that boat. Gender responsive treatment is also really, really important. When we start with separating out our groups, that is a great start. But I'm talking about the curriculum. Is it normed for the individuals coming in? AA was made by men for men, but it was made by men for men without trauma, okay? That's important because we have this undertow, and we've come a long ways, that men aren't supposed to talk about trauma or have trauma, you just do this, right? But also, mental health therapy was created by men for women, as if men aren't supposed to have mental health either, right? Here's the other part of this. There's a lot of research out that indicates that women feel stigmatized, even by their treatment provider, by the court teams, and they feel shame when they're coming into a program and they've been using while pregnant, right? There are curriculums that help us address this special population in a way that helps them with lasting change. Culturally responsive treatment, the one thing I hear over and over again throughout the nation is we're good in that area because we often don't know what we don't know, right? Then when we do the evaluations, when we have somebody come in and evaluate the program and we get the numbers, sometimes we're really concerning is the fact that, well, with ours for one, our Native American women were only graduating at a 3% rate. That's an us problem that we didn't recognize until we had those numbers. And then it didn't matter that we thought we were doing the best we could, we had to change, right? So, like I said, CBT, it is a problem-solving approach, and the one thing in this area I want to talk about is the pro-social thinking, previously known criminal thinking. The research is very clear that all individuals that are high risk, high need should have this curriculum. It doesn't say we should pick and choose based on their behaviors. It says if they are high risk, high need, they should be in a curriculum that addresses their pro-social thinking, attitudes, behaviors, and things like that. Medication for addiction treatment. We've come a long way in this area, haven't we? Even in the last 5 years. There is no research out that indicates that it is helpful for the client to have to stop the use of these medications before they leave your program. In fact, I have a lot of research on this because I'm studying neuroscience. but the way that the brain synapses are changed, we cannot change those synapses simply by having them in our court. And this sometimes has been that missing link. So what is your zone of control? Give me like 1 more minute to finish up. We can ask our treatment providers what they're doing, how they're doing it, and what they need. I had this wish list, right? Every time a new grant came out, I'd like this curriculum, I'd like this one, I'd like that one. I didn't always get them all, but boy, do I have a lot now, right? But also, we can ask more. And treatment providers often like to step up and say, here's what we're doing and here's why, right? For that understanding, so that not only can there be trust between the systems, we know that if an individual isn't necessarily doing well in something, we know what's going on, we know it can be added, and we can have that conversation. Again, you guys have questions?